Good morning. This is Ulf Landmesser from Charité University in Berlin. It's my great pleasure to start a truly global session today on lipoprotein A and cardiovascular risk. We will have three presentations and a discussion moderated by Professor Kausik Ray from the Imperial College London. The first presentation will introduce us into the important data, in particular observational and also genetic, that illustrate that lipoprotein A is most likely a causal risk factor for atherosclerotic cardiovascular disease. We will then discuss with Professor Goldberg from St. Louis, the Washington University, the current management option for patients with elevated lipoprotein A. And finally, and I think particularly exciting, we will hear in the last presentation coming from Australia from Professor Nichols about the future options of treatment, in particular RNA-targeted therapies to lower lipoprotein A that give really the perspective for very effective management in the future of this largely genetically determined risk factor for atherosclerotic cardiovascular disease. We are very tight in timing, and it's my great pleasure now to introduce Professor Nordestgaard from the University of Copenhagen to illustrate us and discuss with us his data and the general data on lipoprotein A and cardiovascular risk. Borge, we are very much looking forward to your presentation.
Thank you so much for this very kind introduction. My conflict of interest are shown just below. I'm talking on lipoprotein A and cardiovascular risk. So I start off with this time scale showing that Lp(a) was discovered by Kåre Berg in Norway in 1963, and then after a number of years, the Lp(a) gene was cloned by Lorne and Scano in the United States. And then it took a long time before we really got things into guidelines. And you can see when you get close to 2010, there was the first guideline or statement coming from Europe saying that we should screen Lp(a), particularly in high-risk individuals. And this was later followed up by other European, Canadian, American, and now also Indian guidelines. But I think a very big breakthrough was here. The European ESC, EAS guidelines on dyslipidemia in 2019 said we should actually screen Lp(a) in everybody once in a lifetime. And this is now followed up by also guidelines in India and very latest in Canada in 2021, also stating that everybody should have a Lp(a) measurement actually as the first lipid test. And here I just show to you to get in perspective on the scale from 1963 until today, how many scientific publications have we had on Lp(a). And as you can see, there was a huge surge interest after the cloning of the gene in 1987. And then there was some studies around 1996 that sort of like said Lp(a) was maybe not so important, and the interest dropped again. But then it was around 2009 resurrected, you could say, by genetics. Suddenly we realized that Lp(a) was causally related to cardiovascular disease. And the new thing is that we heard by Steve Nichols in the end that we have this new Horizon trial that started in 2020 recruiting. So that's generating even more interest. Lp(a) is an LDL-like particle that by a disulfide bridge has a protein called apolipoprotein A attached to it. It has all these crinkle structures that now I'm from Denmark. It was actually named after this Danish pastry, a crinkle. Particularly important is this 4.2 variation, where you can have from 2 to more than 40 different variations. And that's determining a lot of the plasma levels. This crinkle, as illustrated here, has homology with plasminidine, plasminidine being important in fibrinolysis. And particularly the crinkle 4 is found in many different variants, but this very special version, crinkle 4 type 2, is found, as we can say here, from maybe 1 up to more than 40 different copies. Lp(a) developed twice in evolution in the European hedgehog, and then in a different version, somewhat different, in some apes, monkeys, and humans. This is the same version there. So therefore, it's very tempting to think it must have some beneficial effect if it developed twice in evolution. Probably some way it increased survival, otherwise it would not stay here. One idea has come up that it could be wound healing, maybe it stopped bleeding, for example, during childbirth, but this is speculation. Here's the distribution shown for whites, and what you can see here, this is the Copenhagen general population study. It's a skewed distribution with a tail toward very high levels. Approximately 20% have levels above 50 milligram per deciliter. It's 80 to 90% genetically determined, meaning that it's a causal factor because there's really no confounding when you look at it, and there's no reverse causation. The genes always come before you have diseases. Here's some novel unpublished data that I think I would share with you. Dr. Simone has done this in our Copenhagen studies, and we usually say that not much influence Lp(a), but here you can see very clearly as age goes up around age 50, suddenly there's a jump in the Lp(a) levels in women, so they for the rest of their lives they have higher levels than men. So you could say that in women Lp(a) is a relatively more important risk factor than in for women than in men. Another thing that is different is ethnicity, and here's shown Lp(a) levels in different ethnicities. You can see whites, Chinese, Japanese, South Asians have roughly the same levels shown as median interquartile range. South Asians higher, Arabs and Hispanic yet higher, and the one ethnicity with the very high levels is blacks. So blacks has much higher levels than others. It is important now that all the evidence we have so far tells us that Lp(a) is a causal risk factor in all ethnicities. There's been some discussion about is that true, but there's no evidence suggesting that it should not be a causal risk factor for cardiovascular disease in all ethnicities. Here's our own studies, also done together with Nicholas and Ray that are on the call today, where we tried to, in the Copenhagen general population study, head-to-head compare the same increase, 1 millimole or 39 milligram per deciliter in LDL cholesterol with the same increase in remnant cholesterol with the same increase in Lp(a) cholesterol, both looking at observational and genetic evidence. So if you focus on the observational, you can see for the same increase, this is the risk for myocardial infarction for LDL cholesterol, for remnant cholesterol, and for Lp(a). So Lp(a) has, for the same cholesterol content, the highest risk increase, suggesting that it might not only be the cholesterol, but something else in Lp(a) that is important. And the genetic evidence just shows that they are all causally related, independent of each other. Lp(a) is depicted here side to side with LDL and remnants. And what you can see is that the cholesterol in Lp(a) is actually quite little compared to that seen in LDL, again arguing that it might be maybe something with the crinkle 4 type 2 that could be important. Here's how I depict the mechanism. So LDL causes atherosclerosis, so does remnants. Lp(a) is thought by many to cause atherosclerosis. However, it could also be prothrombotic indirectly via fibrinolysis inhibition. Anyway, all three leads to atherosclerotic cardiovascular disease, myocardial infarction, stroke. And here's sort of like when I sum up all the genetic evidence saying that Lp(a) is a causal factor, we know that it causes atherosclerotic stenosis, myocardial infarction, aortic stenosis, heart failure, ischemic stroke, and all-cause mortality. And just to get in perspective, I put some numbers here from our Copenhagen studies, where you can show that actually the risk is for the highest number of Lp(a), highest for atherosclerotic stenosis, myocardial infarction, and aortic valve stenosis, and somewhat less for heart failure, ischemic stroke, and all-cause mortality. Here's some novel data that came out. Anne Langsted is the one that is the first author published in European Heart Journal. What we tried to do here was we tried to illustrate that if we take people in our Copenhagen studies from the top group and bring them down to the bottom group, corresponding to what is going on like in the Horizon trial, what can we, using observational genetic evidence, to estimate? Would there be any side effect? Would there be something bad? And so we compare low versus high Lp(a) and looking at the corresponding Lp(a) genotypes. And what you can see is there's concordant findings. So it's so clear from these data that when you reduce Lp(a), you get less myocardial infarction, less aortic valve stenosis, less ischemic stroke. There's no change in cancer, infectious disease, or other diseases. There's some discordant findings where observational there's association, but not genetic, on mental disorder and diabetes. So we don't think it caused diabetes, but of course this has to be watched in the trials. And here I'd just like to share this data given to me by Florian Kronenberg, published in online in Journal of Internal Medicine. I think it's very interesting these days that what they could show here using data from the UK Biobank, that as Lp(a) concentrations go up, then here's the risk of, in this case, it's ischemic heart disease for higher Lp(a), higher risk. But if you at the same time have had a COVID-19 infection, the risk is higher. So it seems to be even more dangerous to have high Lp(a) if you have a COVID-19 infection. The newest guidelines, the European guidelines, they here show that I think it's the new thing that came through, namely that Lp(a) should be measured at least once in each adult's lifetime. And this is particularly to find the ones with very high, those with risk similar to FH. If I sum up all the different guidelines that has come starting here in 2010, you can see most of the guidelines, they focus on the very high risk. But then there came this change here in 2019, where the European ESC guidelines followed by LAL guidelines in India, and now the CCS guidelines in Canada is saying, let's measure Lp(a) once in everybody. And so my final slide here is just this, the timeline again, that screen in high-risk individuals, but now also screen once in everybody, once in a lifetime. So thank you so much for your attention.
Well, fascinating talk, beautiful overview. Thank you for keeping to time. So we've got a few questions in the chat box, but before I go to those, maybe I can just ask you, many guidelines now recommend looking at Lp(a) at least once in a lifetime, but we know that the assays are not so readily available yet. So before we get there, who is it imperative, just reiterate those points, to measure Lp(a) as a must?
Yeah, but I honestly think so. Everybody should have it measured, like the Canadians suggest now for the first lipid test, and it's not difficult to measure Lp(a). The more it'll be used, the more it'll be available. But otherwise, the ones that are the real high ones you would like to do is the one with suspected familial hypercholesterolemia, the ones that have an early cardiovascular disease or family history of cardiovascular disease. For example, the ones that where you give statins or other LDL lowering medications that you can't really get LDL down. That could be because of a high Lp(a). And then finally, I think the ones that despite sufficient LDL lowering therapy get a second myocardial infarction, these are very, very key to measure Lp(a) in those.
Fascinating. So one of the questions, Borg, that we've got two questions, in fact, with a similar theme, which is, so you've got an individual with an Lp(a) over 100 milligrams per deciliter, 56-year-old, on a coronary CT, coronary artery calcium score of 0, not a single plaque, yet some of the patients that they see have a lot of plaque with similar levels. So what is driving that differential presentation in some but not others?
Yeah, I honestly, I wouldn't know for sure. I couldn't know, and maybe because you have a better idea about that. I mean, it's I don't have a clear answer really. Why?
I mean, I think it's one of these things, isn't it? Because cardiovascular disease is probably multifactorial. There may be different genetic vulnerability. There may be enhancement with other factors. I think that could contribute. I mean, no one variable confers absolute risk. So I think that's probably the answer. But another question, Borg, you talked a little bit about Lp(a) levels in that beautiful figure. Does Lp(a) level change in the lifetime? And if so, how much? Maybe it's worth just reiterating that nice slide that you showed.
No, but it doesn't, and like that's why we did the study women versus men, because there has been this rumor or some previous studies showing that it goes up in women, and we can show that clearly. So it definitely did go up in women after age 50. And when we look into these details, the main explanation for that is actually change in kidney function. It's not also something in estrogen, but kidney function explains the most in the change over age. Otherwise, very little influence.
For women, we should screen twice effectively, before the age of 50 and after the age of 50. So,
for women, yeah, that would be advisable. Yeah.
And the other thing is can you just literally just go over the relationship with diabetes, and before we go to the next talk briefly?
Yeah, so it's observationally, one has found that the ones with the very lowest Lp(a) have a higher risk of diabetes. But when we try to do it genetically, we can't see it's causal. So we don't really know why, but if you have very, very low Lp(a), you have a higher risk of diabetes. Don't know why.
Thank you, Borg. So in the interest of time, it's my pleasure to introduce our next speaker, Professor Anne Goldberg, who's going to talk about current treatment for elevated Lp(a). Anne, the floor is yours.
Thank you very much, Professor Ray. I'm really happy to be able to talk at this event. These are my disclosures. So I'm going to be talking about lipoprotein(a) and the current treatment. What we do know now is that lowering LDL cholesterol improves clinical outcomes. And as you heard, lipoprotein(a) is a risk-enhancing factor, and we probably should be measuring it everyone. The things that we use to lower LDL, lifestyle, high-intensity statin, the addition of non-statin medications such as ezetimibe, we aim to lower LDL cholesterol in high-risk people as much as possible, and also non-HDL cholesterol and ApoB. Also minimizing risk factors as much as possible, including smoking, obesity, diabetes, hypertension. So what does not work is that the things that we're usually doing, such as lifestyle, terribly important, but it does not lower Lp(a). And in fact, with statins, lipoprotein(a) may actually increase by 10 to 20%. Ezetimibe, bile acid sequestrants, fibrates do not lower lipoprotein(a). And evinacumab, the ANGPTL3 inhibitor that lowers LDL even in homozygous FH patients with no LDL receptors, has no effect on Lp(a). So what we do know lowers Lp(a) is niacin, which reduces its levels by about 20 to 30%. However, in patients with the smaller isoform size and higher levels of Lp(a), there's only about 18% lowering. In addition, in the statin era, where people have been intensively treated with statin plus or minus ezetimibe to get the LDLs down to around 60, the addition of niacin did not show any additional benefit to decrease cardiovascular events. These were the AIM-HIGH and HP2S5 study, which may not have been powered to show anything, but nevertheless, they did not show a benefit. And given niacin's high rate of toxic side effects, it's not recommended for this use. So estrogen is very interesting. And as you heard, levels go up in women after menopause. Estrogen lowers Lp(a) and seems to have a greater effect in those with higher baseline levels. However, given cardiovascular outcomes trials, HERS and Women's Health Initiative, where the estrogen therapy was actually started sometime after menopause or in women who already had vascular disease, there was no benefit and there were increased adverse outcomes. This is controversial because the question is, would this be beneficial in women where you start this in early menopause? And would women with high lipoprotein(a) levels benefit more? I don't know that we'll ever have an answer for this. Lomidopide is a microsomal triglyceride transfer protein inhibitor that's approved in the US for treatment of homozygous familial hypercholesterolemia. It lowers lipoprotein(a) by about 20 to 25%. However, it's really only indicated in this particular population, and its use is quite limited due to cost. It also increases liver fat, which is a concern for more general use, and you have to monitor liver enzymes, and people need to be on very low-fat diets. So it's not really indicated for this indication. So PCSK9 inhibitors are interesting. The two that are currently available, alirocumab and evolocumab, lower Lp(a) by about 30%. In earlier trials, you could see every 2-week evolocumab about 30%. In FOURIER, the secondary prevention trial, The effect was a decrease by about 27%. And in patients with high Lp(a) levels at baseline, there was actually a greater relative risk reduction. In Odyssey outcomes, which was included even higher risk patients, Lp(a) reduction appeared to actually be independently a contributor to cardiovascular event reduction. So one considers that in high-risk patients, this is usually secondary prevention, the PCSK9 inhibitor is a reasonable addition. It's not indicated just for Lp(a) lowering, and again, the effect is only about 20 to 30%. Big effects can be seen in lipoprotein apheresis. These pictures are courtesy Dr. Moriarty, and the white column you see is before pheresis, and the yellow column is after pheresis of somebody with high LDL. This is all of the fat in the ApoB containing lipoproteins that are captured in the columns, either a heparin column as shown here, or a dextran column. So what does it do? So when we look at lipoprotein apheresis, we can see that it lowers LDL by about 60% acutely. And the effect on Lp(a) is about 60 to 70% acutely, with about a 30% time average reduction. This is because there's actually significant production of Lp(a) such that the levels go up again within about a week. The use of this has actually been very extensive in Germany, with something like 1,400 people treated, specifically for lowering lipoprotein(a). In extensive prospective and retrospective studies, these are not randomized controlled studies, but in extensive studies show a 70% decrease in major adverse cardiovascular events when you compare the people prior to going on apheresis to after being on apheresis. The problem is that apheresis is time consuming. If you're doing 2 or 3 hours a week, every week, it's time consuming. It's not available everywhere. And at least in the US, it's expensive and can be difficult to get going. So to summarize, we have current treatments that have variable effects on lowering lipoprotein(a), none of them hugely, with the exception of apheresis. Most of the current data are skewed towards secondary prevention. So there's really not a clear idea about primary prevention. The lipoprotein apheresis is probably the most effective, but the least accessible in many places. And what we're left with is aggressive LDL, non-HDL, ApoB lowering, risk factor modification to try to mitigate the increased risk that you see with elevated lipoprotein(a) levels. The other question is what to do about primary prevention is very unclear. And this comes up all the time now that we're measuring it more. And so we are awaiting new treatments that are targeted to lowering lipoprotein(a) levels and the cardiovascular outcomes trials that should really give us the answer. And finally, I wanted to refer back to the European hedgehog. And these are my great niece's hedgehogs knitted by her grandmother. Thank you very much.
And thank you. Great overview of current therapies. So, we are aware that statins can increase Lp(a) levels. It's worth really reiterating that because you started with there are no therapies really at the moment specifically. Can you just really clarify that for a patient with high Lp(a), your approach to statin therapies and maybe statin therapies and ezetimibe and other risk factors?
Right. So if I have a patient, particularly somebody with vascular disease with a high lipoprotein(a), I will be as aggressive as possible to the highest possible doses of statins they can take. And then I start adding medications, ezetimibe, PCSK9 monoclonal antibodies. And then in some patients, I would consider apheresis if they're having continuous events. And currently we do have an indication for apheresis in the US for high lipoprotein(a) levels in patients with continuing vascular events and LDLs greater than 100.
And so the LPA elevations with statins, you don't think that they are clinically relevant?
Well, I think that possibly, you know, this is part of the increased residual risk that we're seeing in patients on statins. However, when you do look at all the clinical trial data and break it down, I mean, people still get a benefit from being on statins. So I think we can, I think that we have to simply accept the fact that the lipoprotein levels go up, and it's actually quite variable. It's not the same for everybody, and it can be, you know, a few percentage points and sometimes a little more.
And so in the first talk, we saw the homology between LPA or apolipoprotein A and B and plasminogen. So what about antithrombotic therapy or antiplatelet therapy? What's the role of aspirin?
I think that at this point, I mean, aspirin has been very controversial as well, but I think that using low-dose aspirin in patients with very high lipoprotein A levels, even in some patients where we're just talking primary prevention, may be a good idea. Clearly in secondary prevention, I think aspirin is a good idea. And there's some data from subgroup analyses of a number of studies that show that the aspirin does help mitigate some of the risk. And so I think that we are moving in the direction of aspirin. It's essentially a risk-benefit issue in terms of the risks of aspirin versus the benefits of decreased risk.
And we know there's a question from the audience about, do we have an explanation for the underlying mechanism by which statins increase LP(a)?
I don't think we do exactly. I mean, there's the question of, you know, is there an increase in production of apo(a) and through some of the cholesterol regulatory issues within cells, but I'm not sure that, I don't think we have a clear-cut idea about that.
Okay, and one final question about diet. So this is early days, but is there any evidence about exercise and low-carb diets in particular improving LP(a)?
I have not seen much evidence of that. And, you know, sometimes there are very small studies that may show a benefit. I actually saw an abstract one year that a vegan diet seemed to improve LP(a) levels, but I have not seen any further data on that. Exercise does not seem to help.
Brilliant. Thank you very much, Anne. So again, in the interest of time, I want to move on to our third and final speaker, Professor Steve Nichols from Australia, who's going to talk about new therapies for LPA. Steve, the floor is yours.
Thanks, Coach. Good morning. Thanks for the introduction. This slide shows my disclosures. So, you know, as we've heard the background, you know, the data is very compelling now that we've got a causal role for LP(a), not only in atherosclerotic cardiovascular disease, but also in the setting of calcific aortic stenosis. And we really understand that now because we understand a lot more about the biology, the data from observational studies, and importantly, the work of Mendelian randomization looking at kind of genetic studies have very much kind of told us that LP(a) plays a causal role in a range of cardiovascular disease settings. As we've just heard from Anne Goldberg, there's a range of current therapeutic approaches that we use for targeting plasma lipoproteins that do have some impact on lowering LP(a), but for the majority of these, we either have no evidence of clinical benefit in terms of cardiovascular endpoints, a lack of clinical trials looking at cardiovascular events at all, and even in the setting of the PCSK9 inhibitors, as we've just heard, while there is an association between LP(a) lowering and cardiovascular benefit, those agents clearly do significant things to LDL cholesterol, which are likely to really underlie the majority of the benefit we see with those agents. So where are we kind of going in the field? And there have been a number of therapeutic kind of avenues which really have moved forward in the last few years. First of all, we've seen a range of different therapeutic approaches looking at antisense therapy, the ability to use single strand antisense agent which can bind to mRNA and therefore lead to degradation of mRNA, less RNA, ultimately leading to less protein expression. We've seen a sequential advances in the technology of antisense therapy. We've seen a number of chemical modifications that enable not only for improvement in terms of affinity for these antisense approaches, but also with more recent developments with a GalNAc modification, we're able to directly target this antisense therapy to the hepatocyte where it can have an impact in reducing Lp(a) synthesis. And with the increasing technology of these approaches, we've seen an enhancement in potency and, importantly, a reduction in the side effect profile as we've kind of extended those therapies. Here you see phase 2 data for pelacarsen, the most advanced antisense therapy targeting Lp(a) in cardiovascular disease patients, seeing dose-dependent increases in Lp(a) lowering, in fact, upwards of about 80% using the 80 milligram dose once a month, which is the dose that's gone through to the next phase of clinical development. As you can see, increasing doses are able to achieve an increasing number of patients who are able to achieve an Lp(a) level lower than 50 milligrams per deciliter on treatment. That's led to the first of the large cardiovascular outcome trials in this space, Horizon. This study will enroll a little under 8,000 patients with established ASCVD. It's a prior MI, prior ischemic stroke, or symptomatic peripheral arterial disease. All patients need to have an Lp(a) level of at least 70 milligrams per deciliter, and they will be treated with either pelacarsen 80 milligrams subcutaneously monthly or matching placebo. We expect the duration of treatment in this trial to be about 4 years. Primary endpoint will look at the combination of cardiovascular death, MI, stroke, and urgent coronary vascularization that requires hospitalization. And we have pre-specified analyses in the study to look at patients with both a baseline Lp(a) of at least 70 or at least 90 milligrams per deciliter. That study continues to recruit. In parallel, we've seen the development of RNA interference approaches that really gives a double-stranded approach to, again, leading to reduced RNA availability and protein expression of Lp(a). Here you see early data from that program, again showing dose-dependent lowering of Lp(a) in the order of up to 80% or more. And again, in both of these programs, the safety profile with these newer agents very much looks reassuring. And so we kind of wait to see the next steps in that program that's currently being evaluated in a larger trial of patients with established ASCVD. Third approach is to really propose the question, can we use gene editing as an additional approach to targeting Lp(a) lowering? The concept of, can we identify patients with a specific genetic mutation which is driving their dyslipidemia, give potentially a one-off therapy to edit that gene and potentially give a lifelong therapeutic approach to treating their dyslipidemia. We've already seen the gene editing approach start to be used in the setting of familial hypercholesterolemia. There's no reason why we won't see this move forward in the future in targeting Lp(a) specifically. Beyond genetic approaches, there are there's small molecules that still are in clinical development that have the potential to lower Lp(a), and really a ghost from lipid therapies kind of gone past, the CETP inhibitors, very well may still provide an additional option in terms of being able to lower Lp(a). These agents were originally developed from their perspective of being able to increase HDL cholesterol. We know that these agents either had clinical futility or, in one case, clinical toxicity. There is one CETP inhibitor, obicetrapib, that continues in clinical development primarily by virtue of its ability to lower atherogenic lipoprotein levels. And you see that in addition to LDL cholesterol lowering, this agent lowers Lp(a) by about 33%. And so as that agent moves forward, it provides potentially another opportunity to see if we can reduce cardiovascular risk in association with lowering Lp(a). And then finally, to kind of pose the question, how much Lp(a) lowering is going to be enough? This is data from Brian Ferentz and his colleagues looking at Mendelian randomization. And you've got data on the left for LDL cholesterol, data on the right for Lp(a). And you have three different analyses looking at the relationship between changes in the level of that lipoprotein and the reduction in coronary risk. You're looking at genetic estimates, looking at the estimates from observational studies, and then importantly, the yellow lines to try and provide some clinical trial estimate of what we see. Now on the left, we know from having looked at a generation of lipid lowering studies that for every 1 millimole per litre lowering of LDL cholesterol, you see about a 22-23% lowering of CHD risk. What degree of Lp(a) lowering, if we look at these kind of Mendelian randomization studies, would you need to achieve to see a similar or comparable degree in lowering of cardiovascular risk? And it looks like it's in the order of 100 milligrams per deciliter, which would suggest, at least from that perspective, that we would have to identify patients with very high levels to kind of bring into these clinical trials or to use in clinical practice. But it may be that it's not quite as simple as that. And it may be that the combination of a high Lp(a) with other risk factors or the absence of those risk factors may determine the relative atherogenicity. And so here you see data from the Accelerate study. This is a study of secondary prevention. And in this study, we were able to show a much greater relationship between increasing levels of Lp(a) and cardiovascular risk in patients with higher levels of hsCRP as opposed to patients with lower levels of hsCRP. And so it may be that ultimately the design of clinical trials needs to think not only about entry points of Lp(a), but concomitant risk factors in terms of trying to identify who has the most modifiable kind of risk to target. And so finally, really what this leads us all in as we search to kind of develop personalized approaches to cardiovascular prevention with the idea of identifying biomarkers that we think might still be driving patients' risk beyond treatment with a statin. We then target those biomarkers with new therapies. As you can see on the right, we are now on the cusp of being able to very much test that hypothesis from an Lp(a) perspective, and it very well may be in the near future that the patient treated with a statin with a high Lp(a) may ultimately have Lp(a) lowering therapies that have reduced cardiovascular risk in clinical trials and will be the next step moving forward. On that note, I'll thank you for your attention.
Thank you, Steve. Superb overview of what's going to come and what is coming and hopefully very soon. So Lp(a), we have to prove that it's causal. This is why all of these therapies that clearly do lower Lp(a) aren't available, because we don't know whether that translates into reductions in cardiovascular events. Now, can you just quickly recap on, you touched on the absolute reduction. So presumably all of the trials are looking at people with very high levels. What is the level in terms of inclusion?
So in the Horizon trial, which is the one cardiovascular outcome trial that's ongoing at the moment, the entry criteria is an Lp(a) of at least 70 milligrams per deciliter. And that's an important point to note, because there will be many patients in that trial who actually have an Lp(a) less than 100. And that really speaks to that point I tried to make in terms of how do we try and balance the projections from the Mendelian randomization studies with what we're going to see in the clinic, what degree of Lp(a) lowering we might see, and will that translate to a reduction in risk? And as I said, we've balanced that on the basis of the fact that there are going to be other factors that are going to be driving their risk in addition to their high Lp(a).
So obviously for primary prevention, and Anne touched on this as well, all of these studies are likely, we always tend to do these studies in people with established cardiovascular disease. So you're a lot further down the road. But surely for a genetic condition where you can essentially reduce Lp(a) by 80%, and then that sort of the base editing CRISPR technology, potentially we've got something that's curative for that primary prevention population.
Oh, absolutely. And I think as Borg and Anne both really highlighted, there's a very strong genetic kind of relationship here with Lp(a). And so the patients who have got really high Lp(a) levels where we have a demonstrated mutation particularly in families where there's a strong family history of cardiovascular disease, particularly premature cardiovascular disease, it would be a very appealing approach to a gene editing therapy. And I think that's very much what's driving a lot of the interest in that space in general. And it does talk to the potential for a one-off approach to primary prevention in the particularly high-risk individuals and their families.
And I thought the data that you showed from Accelerate was fascinating with the high CRP, again suggesting that one risk factor alone, there's a whole milieu of different things. Do we have an idea on what else might enhance risk, for example, in that particular group, other than inflammation?
No, well, I think that you're going to find that it's going to be patients with a combination of a multitude of additional risk factors. Diabetes, in particular, are going to kind of contribute to that. And it does tell us that we need to continue to look at the kind of combination of risk factors and how they identify the more modifiable kind of patient.
Brilliant, thank you. And with that, I'm going to hand back to my co-chair, Professor Ulf Landmesser, to conclude this session. So thank you to all our speakers.
Thank you very much, Kosh. It's my great pleasure to briefly conclude the session. I would also like to thank the excellent speakers and moderation by Professor Ray. We have clearly seen that lipoprotein A is also recommended now in our joint ESC-AAS guidelines to be measured at least once in the lifetime as a risk factor for atherosclerotic cardiovascular disease. We have also very nicely heard from Professor Goldberg the current management strategies, in particular more intense management of other cardiovascular risk factors in these patients, and in selected patients see apheresis treatment, in particular if patients have progressive disease. And we are very much looking forward, and I think the profound genetic understanding and the genetic studies strongly suggesting causality of this risk factor for atherosclerotic cardiovascular disease allowed us now to see these RNA-targeted therapies in clinical trials, and in particular advance now the Horizon trial that will really hopefully provide us the first treatment option to effectively lower lipoprotein A in our patients in the future, that will assess efficacy and safety in high-risk patients. And Professor Nikos already gave an outlook on potential future options of gene editing that is already now in clinical trials, for example, in TTR amyloidosis. And the area of atherogenic lipoproteins is an area where we will likely see this in the near future because we have such a good genetic understanding of the genes relevant to atherosclerotic cardiovascular disease. By that, I thank you very much for your attention. I thank again the speakers and Professor Ray, our moderator, and I wish you a very good further digital congress. Thank you very much.